Dr. Van Spall with us today. Dr. Van Spall completed her Doctor of Medicine degree and postgraduate clinical training at University of Toronto, and then subsequently finished a Master's of Public Health degree at Harvard. She's an Associate Professor of Medicine and a cardiologist with a focus on heart failure and echocardiography at McMaster University. Dr. Van Spall is a Canadian Institute of Health Research funded scientist who leads clinical trials in heart failure at the Population Health Research Institute. She's an adjunct scientist at ICES. She's very well funded across multiple platforms and has won several research awards, published her work in leading journals like JAMA, Lancet, Circulation, and JACC. And then she's a media correspondent, serves as a CIHR College of Reviewer, and is an editorial board member, associate editor, and a peer reviewer at several high-impact journals. We're lucky to have her visit with us, and she's talking to us about hospital-to-home strategies to improve outcomes following hospitalization for heart failure. Thank you.
I am delighted to be here. Thank you for the invitation, and it appears that my slides have disappeared. So today, I will speak to you about a health systems approach to improving outcomes following hospitalization for heart failure. We will discuss addressing the underlying cause very briefly, approaches to optimizing medications, communicating prognosis, offering transitional care services, addressing comorbidities, and addressing disparities. Heart failure, as we know, has a high burden on healthcare systems, accounting for hospitalizations in over 1 million people in the US. It's a secondary diagnosis that accounts for 2 million hospitalizations, and the diagnosis is borne by more than 6 million Americans. This graph is based on data from 300,000 patients in Ontario, Canada, and depicts the lifetime readmission risk following heart failure hospitalization. The initial period that you see here, this camel hump, represents the transition phase, which accounts for 25 to 30% of readmissions in the weeks immediately following hospitalization for heart failure. This is followed by a plateau phase of relative stability, and then a palliation and prioritization phase that occurs near the end of life and accounts for about 50% of rehospitalizations after the incident hospitalization. So these red zones appear to be periods in which one can attenuate the risk of readmission through better healthcare services. The first tenet of improving outcomes, of course, is to address the underlying causes. And I won't go through them because all of us know what those causes are. After those causes are addressed, and actually in tandem with addressing those causes, it's important to decongest patients who are volume overloaded. And there is lots of observational data that demonstrates that inadequate decongestion is associated with the risk of readmission or death. So the goal is really for complete decongestion during hospitalization, and for some patients in the weeks following hospitalization through the administration of IV diuretics. A lack of improvement in decongestion may point to low cardiac states, dominant right-sided heart failure, advanced kidney disease, hypoperfusion, and non-adherence to therapy. So these are important to follow up on. The galactic RCT, the first galactic RCT, was a small trial that demonstrated that despite the way we provide care, early, intensive, and sustained vasodilation did not reduce the primary endpoint of all-cause death or heart failure rehospitalization among about 800 patients who were hospitalized with decompensated heart failure. So no rationale for aggressive vasodilation compared to usual care. And usual care should really focus on optimizing those therapies that have been evidence-informed in reducing cardiovascular death and heart failure hospitalization. This is our guideline committee's recommendations that for patients with an EF less than 40% and symptoms of heart failure, that the 4 pillars of heart failure therapies be initiated: ARNIs as first-line agents, or for those who cannot have access, ACE or ARBs, substituted by ARNIs over time. Beta blockers, of course, MRAs, and SGLT2 inhibitors. And unlike the historic way in which these classes were tested with layering of one upon another class of medications sequentially over time, we recommended that there was no biologic rationale for this. And so upfront therapies should be initiated across all 4 classes at low doses, followed by uptitration of the doses. A drop in eGFR is common among RAS inhibitors and SGLT2 inhibitors, is not associated with worse renal outcomes, and therefore should not be followed by down titration of these therapies unless the drop is significant, and I will cover that in time. This was our work that plotted on the x-axis event rates or risk, and on the y-axis absolute risk reduction. And as you can see, absolute risk reduction is really a function of risk. So as risk across clinical trials increases, it's easier to demonstrate a large absolute risk reduction. And what we show here is with time, so moving towards the left, risk rates, event rates have decreased as background therapies have improved. And with that, absolute risk reduction across classes of therapies has also decreased. What you can see, however, is that consistently ACE inhibitors, ARBs, MRAs, beta blockers, and SGLT2 inhibitors have demonstrated substantial absolute risk reduction across a range of event rates, whereas some of the newer therapies, such as vericiguat, as tested in Victoria, it's a soluble guanylate cyclase stimulator, and the cardiac myosin activator, omecamtiv mecarbil, as tested in Galactic HF, have shown very modest absolute risk reduction despite high event rates. So these agents are not first-line therapies. The more effective therapies are first-line recommendations across guideline committees in the world. I will not show you clinical trial data from trials that tested the efficacy of drugs in the ambulatory setting, since this is a talk that focuses on hospitalized patients. But both ARNIs and SGLT2 inhibitors were tested in the inpatient setting. I should say SGLT2, SGLT1 inhibitor combination. So I'm talking about sotagliflozin. So I will talk to you about those trials. On the background of the Paradigm heart failure trial that demonstrated a 20% risk reduction in the composite endpoint of cardiovascular death and heart failure hospitalization among patients who had NYHA class 2 to 4 heart failure in the ambulatory setting, the Pioneer heart failure trial tested the efficacy of sacubitril valsartan on the primary endpoint of the proportional change in NT-proBNP. And this drug was compared to enalapril 10 milligrams BID, and the trial demonstrated a significant reduction in NT-proBNP from baseline among inpatients with heart failure. It also demonstrated safety. There was no significant difference in change in renal function, hyperkalemia, hypotension, or angioedema among the 2 groups. And so ARNIs are safe to initiate in the inpatient setting on the background of what we know about long-term clinical outcomes. There are 2 clinical scenarios in which the ARNI sacubitril valsartan has not been proven efficacious over ACE inhibitors or ARBs. The first is the perimyocardial infarction setting. In the Paradise MI trial that was presented this year, patients who were half a day to 7 days removed from acute myocardial infarction with high-risk clinical comorbidities, including reduced EF or pulmonary congestion and other risk enhancers, when randomized to sacubitril valsartan versus ramipril demonstrated no significant benefit in the primary endpoint of cardiovascular death or worsening heart failure. The risk reduction was about 10%, not statistically significant, although there was no significant risk. So in select patients following an MI, one might consider an ARNI over an ACE inhibitor, but for the vast majority of patients, there's no benefit to starting an ARNI versus an ACE inhibitor. The second group of patients in which the efficacy of ARNIs has not been demonstrated are those with advanced heart failure. So the LIFE clinical trial was a small trial that was presented this year that demonstrated that among patients with advanced heart failure and recent hospitalization, a strategy of sacubitril valsartan versus valsartan did not decrease the median NT-proBNP, which was the primary outcome, through to 24 weeks. In fact, both groups experienced an elevation in the biomarker, speaking to the importance of initiating these therapies earlier on in the disease course. There might be a point of time beyond which evidence-informed therapies lose their effectiveness and are either not tolerated or even futile. In fact, in this setting, sacubitril valsartan showed a hint towards increased risk with more hyperkalemia and more cardiovascular death or readmission, although this was not statistically significant. Sotagliflozin was tested among diabetics who were hospitalized with heart failure in the SOLOIST trial. These patients had a range of EFs, including preserved EF, and had been treated with IV diuretics, were transitioning to oral diuretics, and 200 to 400 milligrams of sotagliflozin in this population initiated in the hospital or shortly after discharge demonstrated a significant risk reduction in cardiovascular death or worsening heart failure, but this was driven by a reduction in heart failure hospitalizations. So the hazard ratio for cardiovascular death was not statistically significantly reduced, but that for heart failure hospitalization was, with more than a 30% risk reduction in that component endpoint. The AFFIRM heart failure trial tested the efficacy of IV iron among patients who were iron deficient and hospitalized for acute heart failure. Patients had an EF less than 50%, and the strategy of IV iron administered in hospital and in the weeks following hospitalization with dose titrated to degree of iron deficiency demonstrated about a 20% risk reduction in composite cardiovascular death or heart failure hospitalization, barely statistically significant, but a significant reduction in heart failure hospitalizations with a risk reduction of about 26%. So this is an effective strategy in select patients who are iron deficient, even if they are not grossly anemic. There has been lots of observational studies that demonstrate that despite clinical trial evidence, the uptake of heart failure therapies in clinical settings is suboptimal. In this multinational observational study of 68,000 patients who were new users of heart failure drugs in Sweden, UK, and US between 2016 and 2019, beta blockers, ACE inhibitors, ARBs, ARNIs, and MRAs were suboptimally used through to a follow-up of 12 months. The study assessed dose titration within each drug class, discontinuation, and clinical endpoints, and demonstrated that across classes of drugs, ACE inhibitors at the top, ARBs, beta blockers, MRAs, and ARNIs, target dose was very uncommon 1 year from initiation. So 30% in ARNIs, and that was actually the highest proportion of target dose therapies. Lower target dose therapies used in ACE inhibitors, ARBs, beta blockers, and particularly suboptimal therapies in older adults and those with chronic kidney disease. Discontinuation, as demonstrated by the red bars here, was common in ACE inhibitors, very common, 55%, ARBs, ARNIs, and beta blockers, which may speak to a couple of different things. It may speak to intolerance to these drugs or loss to follow-up, and or lack of affordability or lack of adherence. So a few different potential causes. And because GFR is a common reason for drug discontinuation, I thought I'd show you this review of ours that's under review at Circulation that demonstrates that most trials in HFrEF recruited patients with eGFRs down to about 30. There were some trials that recruited patients with an even lower eGFR. Of course, the median eGFRs were higher, but it is safe to administer these drugs down to an eGFR of about 30, down to about 20 in SGLT2 inhibitors. And we know that not only through heart failure trials, but also CKD trials. So DAPA-CKD tested the efficacy of dapagliflozin in patients with chronic kidney disease and showed improved renal outcomes. Now, what degree of change in eGFR is acceptable before we stop therapy is less clear, because the trials were not conducted to test safety across changes in eGFR. They typically publish baseline eGFR, but based on opinion and based on anecdotal evidence and observational studies, a 30% decrease in eGFR is considered acceptable before one reconsiders dosing of these evidence-informed therapies. Look as a first step towards causes of acute kidney injury, particularly volume depletion from overdiuresis, reassess concomitant medications that might be nephrotoxic, use GI cation exchangers in the setting of hyperkalemia rather than stopping your MRAs, and persist with these evidence-informed therapies with close follow-up in those patients demonstrating a reduction in GFR. I'd like to transition a little bit to system factors. We often focus on physician inertia, on medication non-adherence at the patient level, but we must recognize that a vast majority of these newer evidence-informed drugs are inaccessible to patients across the world. For access, the industry partners have to develop the drug for regional markets, which is not always the case. There has to be federal regulatory approval. There has to be price negotiation, which is more effective in single payer systems. I have to say the US costing of drugs is among the highest in the world because of the multiple players. Negotiations are more effective when there is one agency trying to drive down the price. There has to be procurement. Clinicians have to prescribe the drug. Insurers have to approve the indication, and this is driven by cost, which is why negotiating of pricing is so important. Pharmacies have to stock the drug. Some pharmacies rely on local suppliers and do not engage in procuring medications that are provided by foreign suppliers. And then, of course, is the element of the cost that the patients have to bear, which for some patients might be inordinate and require assistance. Not everyone qualifies for subsidized drug costing in many regions across the world, including our country, where we have a single payer system, but adults under the age of 65 do not often get coverage for some of the newer therapies unless they have private insurance. So what are some implementation interventions to improve the physician uptake of guideline recommended therapies? We did a systematic review, few trials published in this area, but found that among a variety of interventions, a multidisciplinary approach to prescribing therapies. So this is typically health professionals across disciplines, not just cardiologists, who work collaboratively and follow algorithms to prescribe therapies. This seems to be an effective approach. It was one that was tested in a before-after study, which I'm not showing because of the pitfalls of before-after studies, but run out of Brigham. I think it was Implement HF that showed that virtual visits by a pharmacist in conjunction with a clinician improved the uptake or the prescription of evidence-informed heart failure therapies among patients who were hospitalized for reasons other than heart failure. So interesting study that focused on patients who did not come into the hospital for heart failure, but it was an opportunity to improve care. The EPIC heart failure trial of 290 patients demonstrated that patient engagement through a 3-minute education video that was electronically delivered as a hyperlink, as well as a 1-page list.
Yeah, no, I just, it went into my spam folder. I apologize. So we're all set to go, right?
Sorry, I think somebody
so much,
on mute. Along with the one-page list of drug classes and medication doses, engaged patients in their conversations with cardiologists. And that strategy improved the optimization of guideline-directed medical therapy by about 20%. So engaging patients may be an effective way to improve the uptake of therapies. A third tenet of improving outcomes is to communicate prognosis to your patients. A majority of patients come into the hospital for heart failure and do not recognize the risk they're at. So about a 5% risk of mortality, 25 to 30% risk of readmission in the month following hospitalization. The issue is that a variety of risk prognostic tools are complicated with 29 to 35 variables that are difficult to use at the point of care. We show that a simple 2-variable risk index based on the length of stay and the number of emergency department visits in the prior 6 months predicts 30-day outcomes following heart failure hospitalization with as much accuracy as the more complex models. For every 1 point of increase in the LE index, so this was based on length of stay, and the score for length of stay depended on the number of days of inpatient stay, and the score for E or ED visits depended on the number of visits in the prior 6 months. So every increment in the LE index was associated with a 21% increased risk of 30-day readmission or death. So simple scores like this can help explain the context of the patient and the importance of adherence to medications, to follow-up visits, and potentially to titrate care to risk. We also show that despite our fixation on EF and these arbitrary thresholds that we use to prognosticate risk and to explain the approaches to medical therapies in patients, that clinical phenogroups, so phenotypes, were more effective in stratifying risk. We looked at 1,700 patients who were hospitalized for heart failure and used unsupervised machine learning algorithms, hierarchical models, clustering models, to demonstrate that phenogroups, which, and these were unsupervised models, so just separated patients based on phenogroups, and then we followed the outcomes to look at how these phenogroups were associated with 6-month and 1-year endpoints, and found that the phenogroups which spanned EF thresholds, spanned the 3 LVF categories, as well as increments by 10%, separated outcomes, as you can see in the left bar here, for all-cause death or readmission more effectively than the LVEF thresholds that were recommended across associations in the guidelines. So be mindful of these phenogroups, which included primarily ischemic heart disease, valvular heart disease, atrial fibrillation, COPD, which really portended the worst risk and something that cardiologists don't touch, right? We don't deal with COPD, but patients with concomitant heart failure and COPD have the worst prognosis, and sleep apnea. The fourth tenet to improve outcomes: improve care transitions. So we usually think about barriers and facilitators of effective transitional care, which is care that we provide patients as they transition between healthcare providers, healthcare settings, from hospital to home. We focus on individual level issues such as cost to patients, transportation issues, patients' engagement in their own healthcare, the way clinicians set up follow-up appointments. And we forget that some of these predictors of care transitions occur at the healthcare system level. And many of our systems do not have the appropriate integration of care to deliver seamless transitional care. So I started off in this career about 8 to 10 years ago. And in our healthcare system, we did not have effective transitional care models. So we sought to build a transitional care model that was embedded in our healthcare system, in a learning healthcare system that adopted evidence and continually changed how it delivered care based on the evidence. We sought to deliver a model that was informed by high quality evidence, centered on patients, tailored to local needs, and measured the effect of the intervention on the outcomes. And the goal was for the data that was generated by this model to then shape knowledge, would then shape practice, which is what a learning healthcare system does. And to implement the change, we sought to understand policy factors. What are the regional economic policy facilitators and barriers? Institutional factors. What were the organizational culture and operational issues that might serve as barriers to integrating care? What were the components of structure, such as EMR, process, workflow across institutions such as hospital, home, and clinic? What were the priorities of the clinicians? How were they remunerated? And what could we do to really engage them in this new model of care? What were patient priorities? What were the characteristics, clinical, socioeconomic, that impacted patients' ability to engage in self-care and in transitional care interventions? What was the intervention that we were going to test and implement? Was there evidence to support it? So much of what we do in healthcare services is ad hoc, based on guesstimation, but what did the evidence point to? And then what were the process that we would have to embark on to implement the intervention? How would we measure the success of the implementation? How would we measure whether the intervention was delivered with fidelity? And how would we define success? And then, of course, what outcome measures would we choose that were relevant both to the healthcare system and to patients? So in terms of creating evidence to inform the intervention, we synthesized clinical trial evidence as a first step in this network meta-analysis of 54 clinical trials that tested the efficacy of various transitional care services. We found that disease management or heart function clinics, nurse case management, so these are nurse-led interventions that encompass navigating the patient during admission, followed up with phone calls and home visits, as well as nurse home visits following discharge, were some of the most effective at reducing all-cause mortality. And these were also the most effective at reducing all-cause readmission following heart failure hospitalization. We then wanted to add an element of patient-centeredness to what would become a threefold strategy for transitional care that encompassed those heart function or disease management clinics and nurse-led home visits. So we engaged patients as research partners, and this was 2014, so it was sort of ahead of its time in doing this. Patients helped define the intervention and also select the outcomes. We used the EMR to recruit patients because we didn't want to burden research personnel and patients with face-to-face visits. We designed an intervention that patients thought would serve their needs. So the intervention was nurse-led as informed by the evidence that we generated, but we involved the next of kin or informal caregiver in all aspects of the intervention. We provided a discharge summary in layperson's terms. And then according to the risk of readmission or death, we offered patients home nurse visits and heart function clinic visits. We followed up patients on administrative data sets to reduce the research burden of face-to-face visits and to include diverse patients in our trial because we did not want underrepresentation of any one group. And then we measured all-cause clinical and patient-reported outcomes because patients didn't care if they were back in hospital for a cardiovascular cause or for another cause. So perhaps some of the clinical outcomes we chose weren't sensitive to the intervention, but they were important to patients. And then we adapted this to the local context, engaging decision makers as research partners. We used a stepped wedge cluster randomized design to test the effect of the intervention because all of the hospitals that were interested in participating in the intervention wanted to receive the intervention. So we did not want a parallel cluster design that would deprive some sites of the intervention. And we sought to create horizontally integrated systems creating networks between hospital and home care agencies and between these agencies and heart function clinics. And in fact, I had to create heart function clinics in some of the regions that participated in this intervention. We used training and reallocation of existing personnel in a pragmatic approach and titrated services to risk to conserve resources. We measured the effect of this intervention in a clinical trial, unlike many health services that are tested in before and after designs, and showed, disappointingly, that the intervention implemented across 10 large hospitals in Canada did not reduce the primary endpoint of time to first composite readmission, emergency visit, or death between the intervention and usual care groups. There was no difference, nor did it reduce the time to first composite readmission or emergency department visit at 30 days. So this was discordant from the explanatory clinical trials on which the intervention was based. We did show that among the component outcomes, there was a significant reduction, so about a 35% reduction in all-cause emergency visits at 30 days. That was the only clinical endpoint that improved, but that the intervention improved all patient-reported outcomes, including discharge preparedness, quality of care transition, and health status as measured by the EQ-5D-5L score. So patient-reported outcomes improved, but clinical outcomes did not, except when you did a sex-specific analysis. So in this exploratory analysis of sex differences in effect of the intervention, we found that the composite endpoint of all-cause readmission or emergency department visit did not improve in men who received the intervention, but did improve about 19% in women who received the intervention, with a sex interaction that was significant with a p-value of 0.024. So exploratory analysis has to be taken with the understanding that this is hypothesis generating. We found no sex-specific differences in the patient-reported outcomes. We did find that women had worse health status in the hospital and derived greater benefit in health status with the intervention than did men, but both men and women improved their patient-reported outcomes with the intervention. So the implications are multifold. Pragmatic trials, by virtue of their design, have attenuated treatment effects compared to explanatory trials. Our patient characteristics, by virtue of the broad eligibility criteria, basically patients had to be hospitalized for heart failure, were older, had more comorbidities, had cognitive impairment, some of them had language barriers, some of them were refugees, some of them were homeless. The delivery of the intervention was flexible using the existing resources across hospitals and home care service agents. The intervention was titrated to risk. So a risk titration may not be effective as a strategy because health services may not be sensitive to change at the more advanced stages of disease. It may be that receiving some of these healthcare services in lower risk patients might have improved outcomes because lower risk patients have more of a modifiable risk of readmission, whereas patients who are high risk or near end of life have a relatively fixed risk of readmission. It may also be that risk models, as we all know, are not perfect. So most of them are limited in their discrimination, particularly when we look at 30-day readmission. Administrative data versus adjudicating outcomes at the point of care results in lower effect estimates. And of course, there's a ceiling effect when governments implement policies, as they did during this trial, that hospitals would be penalized for 30-day readmissions. All hospitals hustle to do things to improve outcomes. And so there might have been a ceiling effect in the intervention. Nevertheless, we showed improved patient-reported outcomes across demographic groups and an improvement in clinical outcomes in females. So these might be things to keep in mind in selecting appropriate patients for these kind of interventions. Another important thing to keep in mind is that transitional care includes palliative care. In this registry analysis of nearly 400,000 patients who died of heart failure, we showed that discordant with their wishes, patients, for the most part, die in the hospital. Over a 15-year time point, more than 50% of patients died in the hospital. A majority of patients who died in the hospital received invasive, intensive care. And among these patients, men received intensive invasive care far more commonly than women. Patients who died in the hospital had a threefold increase in cost of care, both at the last month of life and in the last 6 months of life. This is adjusted for inflation. And a factor that was independently associated with death at home versus in the hospital was palliative care. So receiving palliative care in the ambulatory setting within 6 months of death is associated with a reduction in odds of death in the hospital. So it facilitates care in a way which is concordant with patients' wishes. This is a current trial that we are embarking on, Victory Heart Failure, testing the efficacy of a completely virtual care model to improve care transitions in heart failure. And I hope to come back to tell you about the results of that trial. But a fifth tenet in improving hospital outcomes is to address comorbidities. Non-cardiac comorbidities account for about 50% of readmissions following heart failure hospitalization, something we need to be more mindful of. We showed in this collaborative project led out of the UK that a significant proportion of patients after heart failure hospitalization are admitted due to respiratory conditions such as COPD, infections, kidney disease, GI bleeds. And so these are things we can keep in mind as we come up with a discharge plan. Don't forget those COVID vaccinations, flu shots, pneumococcal vaccinations every few years. And the last important point is to address disparities. We know from a multitude of studies that there are sex differences in the care that patients receive. Women receive later referrals to heart function clinics. They receive invasive care less frequently, so they might derive greater benefit from cardiac resynchronization therapy, but receive CRT ICD less commonly than men. They receive LVADs less frequently. They're referred later for revascularization in the setting of acute coronary syndrome and MI, which is a common risk factor for heart failure. They have higher mortality on the transplant list. In the setting of stable care, they receive medical therapies less frequently. For example, women who have atrial fibrillation are anticoagulated less commonly than women, so have a higher stroke risk, and so on and so forth. So we have to be mindful that we reserve the same kind of care for both women and men. We have to keep in mind that patients of a lower socioeconomic status and those across particular demographic groups receive care in a less ideal way. This study of 4.3 million heart failure hospitalizations that we did using the National Inpatient Service demonstrated that patients with a lower socioeconomic status present to the hospital more commonly with cardiogenic shock, cardiac arrest, and yet receive invasive care less commonly across race and ethnic groups. So you can see low socioeconomic status in blue, high socioeconomic status in red, and the cost of hospitalization across white patients, Black patients, Hispanic, Asian, Pacific Islander patients, and Native or Indigenous patients is much lower in those of lower socioeconomic status, driven by lower procedural volumes in these patients. And after adjusting for all of the clinical factors that might portend in patient mortality, patients with low socioeconomic status had higher risk of mortality. I also want to talk about research disparities in the last couple of minutes. women are under-enrolled across pivotal trials of heart failure, much lower than the disease prevalence or breakdown in women versus men. And a majority of trials do not do appropriate sex-specific analysis. Sex treatment interactions are rarely tested for or reported. And in fact, we found that across 317 trials published in high impact factor journals in heart failure care, that more than 70% under-enrolled women relative to disease distribution. And we define under-enrollment as a participant prevalence ratio of less than 0.8. The proportion of women enrolled in trials did not change over time, and predictors of under-enrollment included sex-specific eligibility criteria that in the vast majority of times were not justified in the context of that clinical trial. Another factor independently associated with under-enrollment of women were having both PIs who were men. And this is after adjusting for other factors. It may be that women PIs design trials in a way that facilitates greater recruitment of other women, or design interventions that, that require less burden on the patient, or place less burden on the patient. But we did adjust for type of intervention, type of funding, type of setting, location, and we found that these were independent risk factors. We also found that patients who were Black, Indigenous, people of color were under-enrolled relative to disease prevalence, and that a majority of trials did not even report race or ethnicity. 20% of trials only included Black, Indigenous, and people of color, relatively proportionate to disease distribution. So vast majority did not. And factors independently associated with increased enrollment of Black, Indigenous, and people of color among all of the clinical trial design factors that we tested for were women trial leaders. So perhaps good justification, not only to be mindful of diversity when recruiting, but to increase the capacity and the recruitment, retention, promotion of women who lead clinical trials. We looked at research disparities also on a global scale and found that Africa and Asia are virtually absent from clinical trials, very discordant from the burden of disease across the world. So as you can see in this graph, the right-sided pie looks at the worldwide prevalence of heart failure. The blue is Asia, the yellow is Africa. So the majority of the burden of heart failure lies in these continents. But these continents represent less than 7% of patients who are recruited into clinical trials. And clinical trial recruitment, based on the infrastructure and leadership and capacity, of course, is dominated by Europe and North America, where a vast majority of recruitment occurs. Why is this important? Diversity increases the external validity of trial results to inform clinical care across groups suffering from disease, allows us with adequate power to test for subgroup interactions, expands the direct benefits of clinical trial participation to these groups, because we know that patients enrolled in trials do better even if they're enrolled in the usual care or placebo group. And it engages diverse groups that may traditionally be disenfranchised from the healthcare system in research to facilitate knowledge uptake following the trial. So multitude of reasons why we must make efforts. We have papers on strategies to increase the diversity in clinical trials from a health systems, health research, and funding perspective. And I would encourage you to read more on those, because we've come to the end of our time here and I want to leave time for questions. So in summary, to improve outcomes following heart failure, hospitalization, address the underlying cause, optimize medications, keeping in mind the role for ARNIs, beta blockers, MRAs, SGLT2 inhibitors, and in select patients, IV iron. Communicate prognosis to your patients so that they know what is at stake and what is being asked of them, keeping in mind that risk-driven care pathways themselves may not be effective at improving outcomes. Offer transitional care to select patients who may benefit from them, address comorbidities, including non-cardiac comorbidities, and address healthcare disparities, keeping in mind the barriers to pharmacotherapy, the barriers to inpatient care, and the barriers to research, recruitment, and generalizability that inform how we deliver care. Thank you so much for having me. I would be delighted to take your questions.
Oh, thank you for that excellent talk. We have a couple of questions already. First is Dr. Berg.
I'm going to try to open up I can't see you all, but that's okay. Fire away. I can't see the questions for some reason.
Oh, no, it's okay. I'm happy to sort of translate.
Should I stop the share?
Can I just ask my question?
Yes, please, go ahead.
Yes, that's great. So thank you. This is really a wonderful presentation, and I particularly appreciated your focus on the need to communicate prognosis so that the patient understands the path that they're on, and also your emphasis on our need to really expand our focus, our research focus to women and underserved populations. At the VA hospital, Parul Gandhi, who I believe is on this call, has championed the use of a more integrated care model that includes not just a nurse with the physician, but also includes the host of allied healthcare providers, including a pharmacist, dietitian, and a psychologist. We know that upwards of 50% of patients with heart failure have depression. And we know that depression is highly associated with non-adherence to medication, non-adherence to any recommendation that is made to the patient that could improve their quality of life, that could extend their lives. Mm-hmm. In the model that you've tested and in the reviews that you presented, clearly that type of service and that type of assessment of the patient and that type of expertise in working with the patient is not included. Mm-hmm. You know, in the review you presented, it's sort of like, well, you can't find what you're not looking for. Mm-hmm. And then, you know, in the trial that you did and that you presented, personally, I was not surprised by the finding. And I was also not surprised by the different effect for men versus women in terms of what we know about how women's social system deal with them when they have a chronic disease. So I guess my question to you is, given what we know about patients with heart failure, what do you see as the obstacles to the development and testing of more integrated care approaches that include the patient as a person and not just a physiology with a disease that responds to different medications in different ways?
So thank you for your very insightful comment. I should mention that in the PACT-HF trial that we assessed, patients were really at the center of what we did. And I reviewed the pre-specified intervention. But for every patient that we encountered, the nurse navigator went and spoke to that patient and their informal caregiver about barriers in that particular patient's journey. And the health status that was reported at baseline was accompanied by, what do you think can we do to improve how you feel and how you function? So some patients actually received occupational therapy at home. Some patients received physiotherapy. Some patients received social work interventions, but psychiatry wasn't part of them because we did not do DSM-4 diagnoses or have the capacity to deliver psychiatric care. But I would say that the intervention was informed by evidence. And if there is evidence that psychiatric care improves clinical outcomes, it's certainly something that can be used as a foundation for implementation. But I would also say that many common sense approaches that we think might improve outcomes based on what we observe in our clinical practice may not actually be those that improve clinical outcomes, which is why it's so important to test healthcare services in a robustly designed trial, which can't be mimicked by before-after studies or the anecdotal generation of evidence. So what I would say to you is, it sounds like you have a great intervention. Test it. And by testing it and showing generating the evidence, it would inform care and change the way we deliver care. Your second part was about the sex differences. Absolutely. We adjusted for the age of the patients because women are on average 5 years older than men at the point of hospitalization. And many women are predeceased by their next of kin, their spouses, whereas men tend to have their spouses to continue to provide care. And we discussed in this article on sex differences that it may have been that the home visits and the multidisciplinary care added little incremental value to the care of men who might have those adequate social supports, but added relatively a lot to women who might lack some of those supports. Now, we did not measure social supports as part of the trial, so this is just a hypothesis, but based on what you tell me, this is something that we've known from observational studies, that women in general lack some of the social support mechanisms. And it might also be why women tend to die at home. They might not be brought to the emergency department as frequently. Now, we adjusted for emergency department visits when we, in our model that established sex as an independent predictor of location of death. But there are many things that we can't measure, of course, in these models. We rely on the data that's there to build these models. So you're absolutely right. Social networks are an important part of the journey, and that's why we involved informal caregivers in every aspect of the intervention that we delivered in this particular trial that I presented today.
Thank you. Let me just clarify. I'm a clinical psychologist. I really don't think psychiatry has as much to offer in this domain,
Okay,
which
perfect.
is largely
Sorry, I heard
medication focused.
I agree.
As a psychologist.
But we never know. Maybe they have something to add. We don't know until we study it. But I agree with you that psychology is a more important aspect than psychiatry. Yes.
Thank you very much.
Perfect. Thank you. And Eric has a question. A wonderful talk, Harriette. Can you comment on the concordance between BPO and morbidity and mortality outcomes? They appear typically discordant, especially at early time points. Do you agree? And if so, can you posit why? And should it drive regulatory approvals alone in heart failure?
What is BPO?
Is it patient-reported outcome?
Oh, patient PROs.
Yeah.
Can you comment on the concordance between patient-reported outcomes? Okay, so we are actually, so the patient-reported outcomes used in this study they were selected by patients over things like the Kansas City cardiomyopathy questionnaire, which we all love to use. Our patients felt that they wanted simple questionnaires that could be administered remotely. These questionnaires were selected to respect their wishes as research partners, but they have not been validated in heart failure, and we're doing that right now. So looking at the minimally clinically important difference, and also establishing independent associations with clinical outcomes. What I would say, though, is in this trial, at least for the time frame that we studied, there was no reduction in clinical endpoints, all-cause clinical endpoints, but there was a reduction in patient-reported outcomes. So they might not be perfect correlates. However, I would argue that patient-reported outcomes are important to patients, perhaps incrementally important as disease advances. I think regardless of whether they correlate with clinical outcomes, they are the people we serve. And we cannot evaluate the care we deliver merely by looking at endpoints, some of which can be played with, right? We have these endpoints of 30-day readmission, but there's gaming that people do and that hospitals do so that they meet the metrics for funding. So you could set up day programs for people who need to be admitted just so that you don't show that readmission. When you don't measure mortality, which is a competing risk for readmission, you can show that policies improve readmission, but they might do so at the cost of death. So I would say there's no perfect measure. I think we need to look at all of these endpoints in conjunction with each other. And regardless of correlation with clinical endpoints, patient-reported outcomes such as health status, satisfaction with care, self-efficacy, I think they're valuable endpoints in and of themselves. But the answer to your specific question will come because we're analyzing these independent associations between these metrics and clinical endpoints.
Perfect. Thank you so much. I think with that, that's a 9, and that's a great talk and great Q&A as well. Thanks for spending your time with us this morning, and we'll look forward to having you in person here again.
Thank you so much. It was my honor. I appreciated the opportunity to be here. Be well, everyone.
Thank you. Bye.